Hello, Team Pinehurst. I'm here to talk today about CKD, documentation, and coding, as this is one of the common problem areas that we have been finding recently. CKD is defined by the presence of kidney damage or decreased kidney function for 3 subsequent months or more, regardless of the cause. As you know, a GFR can fluctuate, which should trigger restaging when the value decreases or increases for 3 subsequent months. The table on the bottom of this slide is a good example of when to restage CKD and when not to. While GFR is the best test to measure kidney function and determine a CKD stage, coding rules prohibit the use of GFR to guide diagnosis code selection. Code assignment is based on the provider's written diagnostic statement. Consequently, providers should include their interpretation of GFR value and document CKD stage explicitly. There are some additional guidelines that coders are required to follow in regards to CKD as well. First, if documentation states 2 different CKD stages, coders are required to choose the lower of the 2 codes. Second, if documentation states mild, moderate, or severe, coders will use the corresponding stage for that descriptor. Please note that mild will map to CKD stage 2, moderate will map to CKD stage 3, and severe will map to CKD stage 4. I did provide a few examples at the bottom of this slide showing how the above mentioned coder guidelines can have an effect. In example 1, the patient was diagnosed with CKD controlled with the GFR remaining at 45. Since coders cannot interpret that GFR value, we have to completely disregard it, making the correct diagnosis code for CKD there N18.9. That, of course, has no RAF value, whereas the CKD stage 3, if the GFR was interpreted, would lead to CKD would have that RAF value. Example 2, the patient was diagnosed with CKD stage 3, controlled, GFR remaining at 45. Since that stage 3 was added in there along with the GFR value, we were able to use that GFR value to guide us to the correct and most specific diagnosis code, in this case being 18.31 for CKD stage 3A. The final example is the HPI states that the patient has CKD stage 3. However, the diagnosis in the assessment and plan states CKD stage 2. Since there are 2 different stages of CKD mentioned, coders will have to take the lower of the 2 stages, in this case being CKD stage 2, which does not have a RAF value, whereas CKD stage 3 did. As previously mentioned, coders choose diagnosis based on the provider's written documentation. Providers, according to CMS, should document any condition that is taken into account or affects patient care, treatment, or management at any visit. Any disease or disorder must be supported by documentation that shows the condition was monitored, evaluated, assessed, or treated, the acronym of MEET, during the patient encounter. For CKD, evidence of MEET might include signs and symptoms such as fatigue and weakness, nausea or vomiting, notation of a physical finding such as edema in the legs or feet, review of lab results with the interpretation, or conclusions about the condition such as the CKD stage, the disease control or medication effectiveness, or the medical management or risk factors. Finally, I did include a table that shows the various CKD stages, the severity and ICD-10 code, as well as what GFR value and renal function percentages map to each of them. The table below that will show any additional codes that are related that should also be documented and coded when they also exist. If you have any questions or concerns regarding documentation and coding of CKD or anything else risk adjustment, please do not hesitate to reach out, and I thank you for your time.